Welcome to everyone that's joining us. We are glad you're here with us today. We're going to go ahead and get started here shortly. Okay, we're going to kick things off this morning. My name is Lindsay Wyckoff, and I'm the Director of Regional Integrated Marketing for the American Cancer Society. It is absolutely my pleasure to welcome you to our event today. We ask that if you are sitting with your coworkers and colleagues in a room together and listening with one another, if you could enter your name and organizations in the chat so we could have a record of your attendance, we would really appreciate it. We're going to mute everyone's line during this program, and we ask that all questions be entered into the Q&A tab on your screen. We will be taking questions during our panel discussion and at the end as time permits. If we do not have time to answer your question during the panel, we will work with the presenters to have your question answered post-event. We're going to kick things off this morning with our first poll question, and that is, what sector do you represent? We will have several polls throughout the program and appreciate your participation. Thank you all for participating with that in the poll because we have great representation across the board this morning. Before we begin our program, we wanted to recognize and thank our sponsors. Without the generous support of the Ohio State University Comprehensive Cancer Center, the James Cancer Hospital, and United Healthcare, this program would not be possible. Also, thank you to the Ohio Partners for Cancer Control and Mountains of Hope Comprehensive Cancer Coalitions for their continued support. Our agenda this morning, we're going to have first a caregiver story, followed by 4 presentations. And then after that, we will have a panel discussion with our 4 speakers. We will conclude with information on the American Cancer Society resources that we want to share with you and a few housekeeping items. The AAFP has reviewed Navigating Social Determinants of Health in Cancer webinar and deemed it acceptable for up to 2 Enduring Materials Self-Study AAFP prescribed credits. You will receive a certificate to claim your CEs within 2 weeks following completion of the post-event survey. Our objectives for today's event can be seen on the current slide. Please note that the planning committee members and speakers have declared that there are no relative financial arrangements or affiliations with the organization that may affect balance, independency, objectivity, or scientific rigor for this CE event, other than that displayed on the side. Also, please note that the slides will be available after the presentation, and we are recording today. Now we're going to move on to our second poll question. Please take a moment to indicate how you are currently feeling about your knowledge of issues in palliative care and oncology. Thank you all for participating. So we have a lot of people feeling somewhat confident. We hope that changes as we get to the end of our program and hear for our speakers. Thank you so much for participating in the poll. We're going to kick things off this morning with Miss Sandra Glenn. She is going to be sharing a bit about her experience of staying in an American Cancer Society Hope Lodge while caregiving for her daughter. Miss Glenn currently serves as a minister at the Prince of Peace Community Church and Healing Center, where she leads the education and healing ministries. She has over 3 decades of experience in teaching both secular and spiritual communities and holds master's degrees from George Washington University and Liberty University. She is married to William, also known as Billy Glenn, and they have a blended family of 4 children, 9 grandchildren, and 3 great-grandchildren. Miss Glenn, I will turn it over to you. Thank you for being here today.
Thank you, thank you, thank you, and good morning to all. I am delighted to be with you today. Um, I am, can you hear me now?
Yes, we can.
Okay, sorry. I am the caregiver for my daughter who is 55 years old, and she currently has been diagnosed with MDS, which is myelodysplasia syndrome. She's had this for a few years and it has progressively gotten worse to the point where she said, I cannot go through this anymore. I have to do the treatment, which was the bone marrow transplant, uh, stem cell transplant. We were very, very blessed in the fact that her son, 14 years old, was a perfect match. So we did not have to go through anything like that. She is a divorced full-time mother with a daughter who is in college, and then the high school student. I say that because that is one of the things that would be on my mind as her caregiver, as her mother, having to bounce the balls and so forth in the air. The treatment was supposed to be for 2 months, which would be from May until the end of July. Um, just so you know, we are still in. She has not been released because we've had setback after setback after setback. We are also grateful that we are at Johns Hopkins Hospital, and we believe that we are getting the absolute best possible care there is. One of the things that I really want to commend Johns Hopkins for is that every time she goes in for treatment, I am given a caregiver report. And that caregiver report provides everything that was done for her that day, everything that we need to do when we go home, and then what to look for in case there is something wrong. Now, one of the other things that was a requirement to undergo this treatment at Johns Hopkins, this procedure, was that she had to be within an hour or 45 minutes away from the hospital in case there was an emergency. Now, although technically we do live within that range, we can never ever guarantee because of the traffic in this metropolitan area that we would ever be able to get there within a 24, I'm sorry, yeah, 24 hour, 8 hour, 9 hour time frame. And so, I'm sorry, 1 hour time frame. I'm getting confused. 1 hour time frame. We could not, but we were blessed to be able to get a spot at the Hope Lodge. And if you're not familiar with the Hope Lodge, it is a facility that supports cancer patients and caregivers run by the American Cancer Society. I call this my Ronald McDonald House because I never ever knew what I was in for in terms of the support that I would get from them. To be in a setting like that where it really was a home away from home, my own little refrigerator space, my cabinet space. More importantly than that, there were people who were there going through the same thing that I was going through. The staff, there are no words to really talk about how wonderful and gracious the staff was and is because I can sometimes drop by. So no, we're no longer staying at the Hope Lodge. We're at a point now where we can stay home because her treatments are every other day. But again, we have not been released yet. I do want to call to your attention an incident that happened while I was at the Hope Lodge. And one night, my daughter went into a seizure. Of course, I panicked because I had never seen a seizure before. And I ran downstairs because I couldn't remember the Hope Lodge address and I couldn't remember a phone number. And they immediately came to my room and helped me get the first responders and so forth in to help us. Well, if you know anything about Johns Hopkins, one of the things they will not do is allow any other healthcare person to work on their patients. And so our, res- uh, our response from them was we had to get her to the site. And the Hope Lodge staff immediately went to work. They pulled up a wheelchair, got a wheelchair, got her into the wheelchair, helped to roll her and get her into the car so that I could get her there. And so I'll forever, ever remember that it was just like being at home. I also want to mention, in terms of the support of Johns Hopkins, that is every single Wednesday, there is a caregivers cafe. And in that cafe, during that cafe, caregivers have an opportunity to share things that they have been going through. Johns Hopkins also provides presentations and speakers who come to let us know what kinds of resources are out there, what things we can expect, what things we need to look for, and just anything that as a caregiver you might be experiencing. When I go back to the Hope Lodge, I also want to mention that in terms of this being a home away from home, I also joke when I think about mealtime. And it's almost like I'm saying, guess who's coming to dinner? Because 3 to 4 times a week, there are meals provided for us by different organizations or even by the Hope Lodge. And so this is, again, is a plus for me in terms of the Hope Lodge. I will never ever stop praising the Hope Lodge for what they do, for the services and facility they give us, because I, going into this, had no idea what it would mean driving an hour or two with my daughter being in the shape that she was in, getting to Johns Hopkins. So thank you for this opportunity to share this. I am still in the caregiver mode, and she still does not have a release date. But I say thank you, American Cancer Society, for all that you're doing, and certainly thank you, the Hope Lodge, for being there for us and being there for me. Thank you.
Thank you so much, Miss Glenn, for sharing that personal story. We are really glad to hear that our Hope Lodge community is providing that support, and we're proud of the support that our Hope Lodge communities are providing across the country in 31 different locations. We always like to kick off our calls with hearing directly from someone to remind us that these issues that we're about to discuss really truly impact the lives of patients and caregivers in important ways. Thank you again, Miss Glenn. We're so glad you're
Thank
here.
you. And I'm off to Johns Hopkins as soon as I leave.
Well, we wish you guys all the best. Thank you
Thank you.
again for joining us.
Thank you.
It is now my pleasure to welcome our first presenter. Dr. Christy Newport is the Chief of Palliative Care at Penn State Health. She completed her internal medicine residency at Penn State Hershey Medical Center and her hospice and palliative medicine fellowship at the Virginia Commonwealth University. Her scholarly and clinical priorities focus on caring for people early in the course of serious illness and training non-palliative clinicians to provide care that is consistent with their goals, priorities, and needs. When not working, she enjoys running, gardening, and spending time with her spouse and 2 children. Welcome, Dr. Newport, and thank you for being here today.
Thank you so much for giving us the opportunity to talk with you today. I really appreciate the American Cancer Society for focusing on palliative care. I appreciate all the folks that brought us here today. And those of you who are attending, I appreciate you taking the time out just to think a little bit about how we can improve the care for our patients, and really appreciate hearing from Ms. Glenn today. Thank you for taking time out of what we know is a really busy schedule as a caregiver, and we all hope the best for your daughter. So, as mentioned, I practice at Penn State Health, and that's in South Central Pennsylvania. The majority of our patients are in suburban or a rural setting, and I spend most of my time in our outpatient clinic, and the majority of my patients do have cancer of some sort. So, Shauna, go ahead and advance the slides. So, I see in our chat that a lot of you practice in palliative care. So, hopefully, for most of you, this is not a new concept, just to think about what specialty palliative care is. But just to level set for all of us, it's specialized medical care for people with any serious illness. It can be delivered at any stage, any age, and any type of cancer, regardless of the intent of treatment, whether it's curative or life prolonging. Can be delivered in many different settings, in clinics, in hospitals, in nursing facilities, or in the place that a patient calls home. And something that's unique about palliative care that I think we're highlighting here with the involvement of a caregiver is that it really is directed towards both the patient and the people who are in their lives helping to support them. And ideally, when we do this well, it's integrated into cancer care. And I'm so pleased that you are going to be hearing about various models of doing that from the folks on our panel today. Next slide. So I really like to kind of summarize this because, if you're introducing palliative care to a patient or family, or you're sitting down with them for the first time to help them understand why palliative care might be helpful, you're not going to tell them that whole diet or that whole definition, right? And so help with coping, I find, is the really simple and palatable way to introduce this to patients and families, and sometimes even to other providers. This is really what's been borne out in our literature, and I find that this is a really easy way for myself to introduce to patients when they first sit down with me. I always ask them in our first visit, "What do you understand about why you're here with me?" And I help them to say, "We're here to help you cope with all of this." That can mean coping with physical symptoms, with emotional challenges, or with just the practical needs of getting what you need to cope with this and to help you to make some difficult decisions. Next slide. So, just so we're all on the same page about when specialty palliative care is involved, how we benefit our patients. This is really a summary of significant evidence that we have, particularly for patients with advanced cancer in the outpatient setting. Again, it really all falls under this idea of improved coping. When it comes to symptom management, we see significant improvements in depression. When it comes to the things that the patients tell us about, they can have improvements in their quality of life and their satisfaction with the care that they're receiving. And again, as different than other interventions in cancer care, we see improvements in caregiver depression, in their stress, and in the satisfaction that they have with the care, in addition to improved coping even after their loved one dies. When we do this well, specialty palliative care can help to align care with the things that matter most to patients. And that often means that they are receiving less aggressive care at end of life. So this means that less people die in the hospital, if that's their preference. Less people are receiving chemotherapy in the last 30 days of life, and they spend more time in hospice in their preferred location. Interestingly, even though less aggressive care at end of life, some of our studies have demonstrated that palliative care can help people live longer despite their cancer. All of the studies that have evaluated the timing of involvement of palliative care have demonstrated that earlier involvement is better. And interestingly, again, different from many cancer interventions, there are no significant adverse outcomes with specialty palliative care involvement. So it kind of seems like a no-brainer to get involved, right? So we'll be hearing today, what are some of the challenges of getting specialty palliative care involved? Next slide. So this evidence is the support that has led the American Society of Clinical Oncology, or ASCO, to recommend the guidelines of having palliative care involved early, particularly with people who have an advanced cancer that can't be cured. The recommendation is that specialty palliative care should be involved within 8 weeks of diagnosis, that the palliative care team should be available both on the inpatient and outpatient setting, and should be an interdisciplinary team. So I'm so glad to see multiple interdisciplinary folks represented on this call, including social workers and spiritual care and nursing and psychologists. The essentials that need to be present for specialty palliative care delivery include relationship building, expert management of distress and symptoms, discussion of prognosis, helping people to identify their goals and help them to make decision making to decisions that are important to them. And this really should be in the setting that's embedded within palliative care or within oncology care, and should also include efforts to target caregiver needs. Next slide. So, of course, this is a challenge to deliver. I'm sure a lot of you that are deliver care in cancer clinics have faced the challenges of not having enough specialty palliative care clinicians to actually meet this guideline, right? And I would say that we are in the same boat at Penn State Health. So more of our studies recently have been helping us to identify, well, how do we dose this appropriately? Right? And how do we really determine how to make this the most effective if we can't do what the original studies did, which was see patients every month throughout the course of their illness? When the early studies were done in the early 2000s to look at palliative care involvement, we were in a very different place in terms of cancer care, right? Particularly the studies that looked at advanced lung cancer. we see that patients are fortunately surviving longer, living longer on cancer treatments. And so that changes the way that specialty palliative care has to be involved. And our recent study that was completed by Dr. Temmel and her team looked at this stepped approach to involvement in cancer care. And so instead of just having a regular monthly visit, they looked at, can we link the palliative care to different changes in their care or their condition? And so they looked at palliative care involvement at times of hospitalization, progression of disease, or changes in their quality of life. This did result in fewer palliative care appointments, but still maintained symptom management, quality of life, and patient understanding of their illness, as well as management of depression. They did see that people spent a shorter time on hospice, but overall, it was felt that this approach could be equivalent and could make better use of a scarce resource. Another opportunity that we have for delivering palliative care when it's difficult to see patients in the clinic on our next slide shares the opportunity to use telehealth to improve access. And, many of us had to jump right into this during COVID, but I will say that even since that time, we have maintained about 40% of our outpatient visits are completed via telehealth. And as I mentioned, that has helped us to reach a lot of our rural patients who are driving maybe 2 hours to come to our cancer clinic. We find this anecdotally to be helpful to improve access in our clinic, but we also see this in the literature. So studies of telehealth benefits demonstrates that we can actually provide equivalent or even improved symptom management for patients via telehealth. And we can do so in a way that's less costly and burdensome to both patients and to healthcare systems. It does at times help us to reach patients that are difficult to reach if they come from a rural place. And allows us to continue to care for patients even if they've enrolled in hospice or are having more difficulty coming to the clinic. Now, of course, any intervention, we have to think about the limitations. And we do have patients that don't have access to broadband internet. And with our current payment structures, utilizing video is really incentivized. And it's very difficult for programs to have a robust telehealth program that's only based on telephone access. And so that is still a significant challenge. The other piece, of course, is that we can't perform a physical exam over telehealth. And so we've told our patients, if you have a new symptom or a change in a symptom, we're going to need to see you so that we can really make sure that we are identifying any interventions that are needed and get them the care that they need. Next slide. Another opportunity to provide palliative care for folks who might not be able to come to the clinic is the utilization of home-based palliative care. Frankly, we don't have as much evidence to really understand whether this can deliver the same kind of quality care that we see via telehealth or in the outpatient clinics. And part of that is because there really is no regulation to say what is a home-based palliative care program. The studies that we do have demonstrate that home-based palliative care can help people who want to stay at home until end of life to do so, and that it can help to control symptoms, and it can do so in a cost-effective way. I do want to point out, and I think probably all of you have seen this in your regions, that there's wide variability in home-based palliative care programs. And so some of the two pieces that have risen to the top of our evidence to say that they really are necessary to be an effective home-based palliative care program is number one, that there's 24/7 availability to actually talk with someone about new symptoms or new issues and to provide home visits if needed, and that there's expert symptom control and communication. And I would argue, and I see in our region, that this expert symptom control needs to be delivered by a provider. So some programs that may be linked to a home health program, they put the label of palliative care on a program, but they may not even have a provider who has palliative care expertise. So if you are thinking about partnering with a program like that, that's something to really be thinking about is there really some good expertise that's going to provide the care that patients need in their homes? Next slide. So while we're talking about specialty palliative care and the importance of that involvement, we don't want to neglect the fact that there are elements of palliative care being delivered to our patients all the time by folks who don't have palliative care in their title. And so that brings us to this idea of primary palliative care. And this is really kind of the set of competencies that all providers should have who are caring for people with serious illness. And we will look at what those elements are. It means that all providers who are taking care of people with cancer should have the ability to assess and manage symptoms, at least with a starting point, right? And so this is our oncologists, our surgeons, our radiation oncologists, all should have the ability to kind of start with symptom management. They should be able to assess performance status and consider how that contributes to prognostication and help people to understand what to expect from their illness. And most importantly, to be able to think about prognosis and think about someone's treatment options and elicit patient goals to be sure that they are recommending interventions that are appropriate for patients and their families. And so this is also, as we're thinking about specialty palliative care delivery, we should always also be thinking about how are we ensuring good primary palliative care is also being delivered through our education and our advocacy and utilizing community resources to be able to do this. So thank you so much for your time, and I'm really looking forward to hearing from Dr. Agnew next about a specific model of how to deliver specialty palliative care.
Thank you so much, Dr. Newport. As she mentioned, our next speaker is Dr. Julie Agnew. Dr. Agnew is a palliative care physician and early career investigator whose research centers on the implementation of palliative care services for patients and care partners during cancer care. In 2018, she implemented an embedded palliative care clinic in thoracic medical oncology for patients with advanced lung cancer. She has published research on logistical barriers to outpatient palliative care delivery, the impact of palliative care on healthcare utilization, and the expansion of the catchment area of palliative care through an embedded clinic model. Dr. Agnew, thank you for being here today.
Thank you so much. I really appreciate the introduction. I'm also very excited to be able to talk in this forum and contribute to the discussion about different care models for palliative care delivery. Next slide. So this is how we tend to think of standard oncology care. Many patients, whenever they're first diagnosed with a malignancy, they quickly find that they have a team of practitioners, doctors, nurse practitioners, who provide cancer treatment. And everyone has their particular realm of cancer treatment that they manage and deliver. So we have our medical oncologists who handle the systemic therapies, radiation oncologists who deliver radiation, and then surgical oncologists if surgery is needed. Next slide. Now, the most common form of outpatient palliative care in the United States is a freestanding palliative care clinic model. And often it can seem like palliative care is outside of the patient's cancer team that is treating the cancer in the outpatient setting. This is true at Ohio State as well. For over 20 years, we have had a freestanding palliative care clinic which operates in a distinct location from our cancer clinics. And the benefit of a freestanding palliative care clinic is that patients can go to a location that's different from their oncology team. It creates a little bit of physical distance from where they're receiving treatment. Some people prefer that. And it also allows the medical center to provide palliative care to all of the cancer patients in their institution. Next slide. Now, we noticed in a freestanding clinic, we had one issue that really came to light for our patients with advanced lung cancer, and that is that despite all of the research and all of the published studies about the benefits of palliative care for patients with lung cancer, patients were not being referred to our freestanding palliative care clinic. And when we dug a little deeper and asked our providers and our patients why they were not referring patients to palliative care, a logistical barrier came to light, and that was that with patients receiving cancer treatment every 2 to 3 weeks for advanced lung cancer, they just couldn't fit in an extra appointment in a new location that was different from their oncology team. And so many patients just didn't want to come to a palliative care clinic that was freestanding. So what we did in 2018 is we decided to bring palliative care to the patients. We embedded a palliative care physician in our thoracic oncology clinic that would see patients alongside the oncology team during their regularly scheduled oncology visits. This didn't require an additional appointment, And it didn't add any extra time that patients were in the medical setting. That's because a patient would arrive for their regularly scheduled oncology visit, and palliative care would see the patient during any of the downtime that they experienced during their appointment. Many times, patients would be waiting in the clinic to see their oncologist, or they would be between seeing their oncologist and moving to infusion, or sometimes they had an infusion that would last multiple hours. All of these areas of free time was a great opportunity for a palliative care provider to see the patient, do a symptom assessment, assess coping, and really meet the patient where they were. Next slide. So, being at an academic institution, anytime we do something new, we like to study it because it shows impact and allows us to determine, what was, the effect of starting a new clinic, such as an embedded clinic. And so, one of the most striking results that we found is that it actually expanded our catchment area for palliative care. We have patients across the state of Ohio who come to Ohio State to receive specialty oncology care, and they just can't make the extra trip to our freestanding palliative care clinic. And so by combining palliative care in our oncology clinic, we found that patients from outlying areas were more likely to receive palliative care from our institution. So much so that it was actually a threefold expansion of referrals for patients living outside of Franklin County, where Ohio State is located, and outside one of the 6 surrounding counties that are adjacent to Franklin County. Next slide. What was even more exciting is the impact on healthcare utilization for our patients with lung cancer. After we embedded palliative care into our thoracic oncology clinic, across all of our patients who were seen by thoracic medical oncology, we saw a 26% reduction in ED visits, which was statistically significant. We also saw reduction in hospitalizations and ICU admissions, which were not statistically significant due to their sample size, and no difference in 30-day hospital readmissions. When we put these reductions into dollars, it was an estimated $2.7 million in annual cost savings. And that cost savings not only saves the hospital money, but more importantly, saves money for our patients. What I think is even more important and not able to be captured is what is the time that we're saving patients and caregivers by combining palliative care with oncology care. If we are reducing ED visits and we're reducing hospitalizations and ICU admissions, not only is that better patient care, but that's also more time that our patients are spending at home and outside of the medical setting. One question that was posed is, why were ED visits decreasing after a palliative care consultation? And we hypothesized that it was improved symptom control, that issues such as pain, nausea, and vomiting could be addressed by a specialty palliative care provider to improve the symptoms that a patient was experiencing during cancer treatment. We also have the ability to administer pain medications in the clinic and also give access to our palliative phone triage to our patients and caregivers so that they can call in whenever they're having issues related to symptoms. Next. This has really been an exciting journey. And while we started with just 2 days per week of an embedded palliative care clinic, after showing the impact from our study results, our cancer center has expanded this clinic to now 5 days per week and an additional physician provider. And we're looking forward to future expansion as this model continues to grow. Thank you very much.
Apologies for the delay. My computer was giving me the dreaded circle. Thank you, Dr. Agnew, so much. I think my biggest takeaway is giving patients back time. It's our most valuable resource, and I just love hearing that. So I'd like to welcome our next speaker. It is Dr. Priyal Patel. Dr. Patel is a pediatric hematology, oncology, and pediatric palliative and hospice provider at Nationwide Children's Hospital. She is a graduate of New York Institute of Technology, College of Osteopathic Medicine. And after medical school, she completed her pediatric residency, pediatric hematology, oncology, blood and bone marrow transplant fellowship, and pediatric hospice and palliative medicine fellowship at Nationwide Children's Hospital. Dr. Patel, thank you for joining us today.
Thank you so much. So I wanted to highlight some of the differences and similarities between pediatric hospice and palliative medicine and adult, because there are some nuances that are important to know if you're caring for a pediatric patient. Next. So as we discussed, I have a unique perspective on the combination of oncology and palliative care. I trained in both. And at times, the reason I highlight this is at times they complement each other very well. And at other times, it can actually cause a little bit of friction and moral distress because some of the goals are probably not as congruent all the time. I am also the Hospice and Palliative Care Fellowship Director and am part of the embedded palliative oncology clinic here. Next slide. So when we think about pediatric hospice and palliative medicine, some of the domains, most of the domains are actually very similar to the ones that have already been discussed for adult palliative care. So first, we rely heavily on our psychosocial team because psychosocial health of the patient and psychosocial health of the family is imperative to holistic care and comprehensive care. So here at Nationwide, that includes psychologists. We have school liaisons, for example, that help kids who are getting treatment still continue their schoolwork and graduate on time if they're in college, kind of help navigate that. We have a lot of specialized psychologists that can help with sibling bereavement. They can help with bereavement of just like anticipatory grief from family and the patient, and kind of can help with anxiety around hospitalizations and different types of treatments. Ethics and legality are an important part of any type of hospice and palliative medicine. I think in pediatrics, there's some unique features. So for example, most of our patients are under the legal age of what is defined as ability to consent. So most of them are under 18. They can assent at around 8 to 9 years. I think every trial kind of defines that a little differently, but they can have enough awareness to at least say, like, I want to do this trial. However, even if they do not assent, if the parents consent, the assent typically doesn't mean much, which can become morally distressing. So, and also another part that we can talk about is the spectrum. So a lot of our patients may have multiply relapsed cancers, or also may have secondary cancers years after the initial diagnosis. So when they were first in treatment, they may be under the age of 18, but as they kind of undergo their hospital course and their medical course, they might turn a legal age. And at that point, some families, there might be friction, because if the child wants something else, but the parents want one thing, I think a lot of times, even if they're legally adults at this point, they're so, like, the patients are so used to just having decisions made for them. So I think those unique perspectives have to be noticed. And also, I think in oncology, sometimes we also struggle with if a patient is, even like, we had a 21-year-old recently who has 5 kids of his own, and the oncology team never spoke to him directly about the terminal nature of his brain tumor. And they always spoke with his stepdad and mom. So when we got involved and we told him, he was very surprised, even though he's 21. I think the practice typically is like we talk with the parents in oncology. So even legally, if it was necessary for him to know the information, it becomes conceptually hard for some providers to actually conceptualize that. Spirituality is a big part of palliative and hospice care. A lot of times, spirituality can inform medical decision makers and just complex decision making, especially around different trials and end of life care. So we have a robust chaplaincy group that can help with it. So, for example, we also recently had a family that their spiritual framework was that if they even acknowledge that the cancer exists, then God will punish them. So it was very difficult. You know, this patient had a cancer that had a 95% cure rate. So then that tied in with legality. The family was not consenting, but because they're surrogate decision makers, unfortunately, or, you know, CPS was involved. I think there were better ways to communicate with the family and align, but CPS eventually got involved and took medical decision making away from family, because legally the concern was that if this is a cure, like mostly curable disease, then it's not in the best interest of the child if parents decline. So that can become kind of a contentious area. Physical symptoms, which is similar, we deal with a lot of different types of like symptoms, including pain, neuropathy, secretion management, all different types of things. And we use multimodal types of treatments to help with that. And then we talked about end of life care. I'll tie in end of life care and structure and process together because each pediatric palliative group kind of has a different structure to how they navigate end of life care. So even though medically they might do the same thing, where they can offer the care can differ. So we are lucky here that we have a home-based hospice and palliative care group that's aligned with our, like Nationwide has its own home-based hospice, and then we are the inpatient team. And it allows the home-based hospice team and the palliative care team is an interdisciplinary team that has chaplains, child specialists, therapeutic recreation, massage therapists, social workers, nurses, physicians. And this interdisciplinary model can help with not just physical symptom management and end of life, but all of the other domains as well in the home setting. And then we also have the ability to do inpatient care at end of life if that's what the family desires. And then bereavement and grief, this is a topic that's near and dear to my heart. And I think it's often, whether it's adult medicine or in pediatrics, it's often a topic that is ignored, or at least it's forgotten because there's other things to do. So I think our palliative and hospice group has tried efforts to improve help with bereavement and grief for both siblings and families and adults. Next slide. So some common pediatric hemonc and pediatric hospice and palliative medicine considerations that you might encounter if you're dealing with the pediatric patient is the difference between palliative care versus hospice with concurrent care. So in pediatrics, under the Affordable Care Act, we are lucky to have this law that essentially says if a patient is less than 21 years old and they have a form of Medicaid, then they qualify for something that's called hospice with concurrent care. What that means is they can get the traditional hospice benefit. So if they have a terminal illness or concern that they have a poor prognosis, they can get all of the hospice benefits that you typically would. So that would include home-based hospice benefits with IDT support. The concurrent care piece means that the traditional insurance will continue to pay for any interventions that the patient wants or the family wants. So that could be radiation, surgeries, oral chemo, clinical trials, all of it. And what this allows historically is there's a lot of moral distress about, quote, giving up on pediatric patients from the providers and the families. And a lot of families require they need the home-based support, but they might not have the goals that are congruent with what typically hospice goals would be. So if they want to continue the treatment, they can kind of have both worlds. Under adult care, if a patient is over 21 years of age, they either choose hospice benefits or treatment. And if they're on the treatment arm, then they can do palliative care, for example. But a lot of palliative care home-based places might not have as many offerings. So they might not be able to do, for example, symptom management. They might only be able to do visits like once a month at home, things like that. So the hospice with concurrent care can be very, very important. And like if you look at data, there's not a lot of data on this, but if you look at the data that is present, a lot of patients that are actually on hospice with concurrent care, they actually live longer and they live more comfortably. So they might continue the treatments that might offer life prolongation, but on top of that, because of the hospice benefit that they're getting, their quality of life is balanced with that. And then ethics and clinical trials. The reason I put this, it kind of gets into the consent that we kind of talked about before. Clinical trials, we do a lot of clinical trials at Nationwide Children's, and a lot of the clinical trials are phase 1. So their purpose is not to cure cancer or even look at the treatment or efficacy. It's more to just prove that it's safe to give. But oftentimes the way it's sold, or at least the way the parents perceive it, is like this could be a hope. So oftentimes I think the verbiage that is used might give a little bit more hope than the actual trial can offer. And also, this also gets into the age of consent, right? So if you're enrolling by the time pediatric patients are enrolling onto clinical trials, it typically means that they've kind of exhausted all other curative options and there's like really not much hope in the cure. So a lot of times, especially for patients that are aware, they might not want to do this, but then that might conflict with family goals. So how palliative care can help navigate around that. second victim trauma and distress. I like to point this out because our entire team, medical and psychosocial and nursing, all of them, take care of really patients that are really sick, and their children. They deal with a lot of loss and a lot of this, societal fear of like losing a child, right? Um, and a lot of times, a lot of, especially your bedside staff, don't have the space or even the time to actually process through that. So oftentimes what happens is they go from one kid who is dying of cancer to another kid without actually having much time to process through it. And that over time can lead to burnout. And also statistically has proven that retention of staff that are burnt out because of second victim trauma is really poor. So palliative care, at least in our hospital, we do a lot of debriefings with the providers that may have some distress. So I think palliative care oftentimes, this is like a part of palliative care that's not seen typically, and it's not something we can bill for, but oftentimes a lot of our day can be just navigating the distress of providers. And that could be our role. And then legacy building and bereavement, I'll put together. So a unique aspect that we're doing some studies at Nationwide Children's, because a lot of families want to legacy build to remember their child and make some meaning out of a horrible disease. So a lot of them will start funds, a lot of them will start organizations or volunteer, things like that. And one of the things that we're now studying is the concept of participating in autopsy studies. So for example, in our neuroonc patients with DAPG, which is 100% terminal illness, and it's a pontine tumor. So it's 100% fatal. So there's no cure for it. And a lot of these families are now choosing to participate in autopsy studies. And one of the reasons that they cite as one of the most important factors in choosing autopsy study is to contribute to science for hopefully for meaningful treatments in the future for DAPG. So autopsy is typically linked with a lot of legacy building for the family, and we are currently studying that, and we're using an interdisciplinary team approach to navigate these conversations around what the autopsy shows and how that information will be used for science. And then bereavement, we have started a bereavement group at Nationwide Children's to kind of formalize the bereavement process. Unfortunately, less than 50% of major pediatric hospitals in the nation actually have bereavement resources for siblings. Oftentimes, the siblings they're considered forgotten mourners because oftentimes the bereavement is focused on the parents, but the siblings typically kind of get lost in the mix of all of it. So we're looking at IDT support for siblings throughout their life because this can have profound impact on their own well-being and their emotional intelligence. So thank you for listening to my spiel on pediatric palliative care, and I'm happy to answer questions later.
Thank you so much, Dr. Patel. That was so informative, and one of our viewers called it a game changer, and I totally agree, especially the care for the families. I think that that's so important. Our next speaker is going to be Dr. Marcin Twistek. He is originally from Poland and pursued a medical career that led him to the U.S., where he specialized in pain and palliative care. He also brings with us the hardest pronounced word of the day as he began his journey at Jagiellonian University. I don't think I did that very well. I'm going to ask you to say it again. Medical College in Krakow, and included significant experiences at Memorial Sloan Kettering Cancer Center and the University of Pittsburgh Medical Center. Today, he focuses on improving patient care through innovations in clinical work and research at Fox Chase Cancer Center. Thank you so much for being here today.
You did very well, thank you. And good morning, everyone. I'm very excited to be here with you all, and was really impressed by the presentations that I heard earlier, and they really speak to the breadth and complexities and nuances related to palliative care in cancer. So I just wanted to sort of introduce myself and highlight maybe a few issues that are sort of close to my heart and my clinical and research work, which I think also reflect the sort of the changing nature of palliative and supportive care in oncology. So I practice, as mentioned, at Fox Chase Cancer Center. We see patients in the outpatient department, have really robust outpatient program, and also in the hospital. So sort of manage patients with mostly advanced cancer throughout their trajectory of illness, focusing on symptom management and goals of care discussions. A lot of our patients, also have interest in managing cancer pain, and a lot of our patients we manage longitudinally for sometimes years following their cancer experience for cancer-related pain. So I wanted to talk about few things that I think might be important, and happy to expand on this during our discussion. So maybe we should start by sort of, providing a little bit of a historical perspective. I always like to do that because I think we oftentimes forget, how far we've come, and how important it is to really see the trends in modern oncology, because I think things are changing really dramatically, and with consequences for patients and caregivers, but also clinicians. So historically, very briefly, for millennia, from 300 BC to about, beginnings of the 20th century, surgery was really the only option for a lot of patients. And surgical treatments, typically sort of resection of tumors, whether palliative, and we could call surgeons the first palliative care providers, because many of those surgical interventions were not targeting cure, but really palliation of symptoms, was the major treatment modality, until about early 1900s, when Marie Curie started to use X-rays, and that sort of ushered us in the modern era of radiation oncology. And then during the World War II in 1940s, chemo came around, and for most of us who've been doing this for quite some time, for decades, the chemo, radiation, surgery were just the main three modalities of treatment. And I think, in a sense, things were somewhat predictable during the time, and maybe a little bit easier to prognosticate, in a sense. But now, with actually a lot of progress that has been made in the last few decades, primarily with the targeted therapies that came around 1980s, and then most recently the immunotherapies, things changed dramatically. And I think they change for patients and caregivers, and again for clinicians, because we do need to respond to them. Those are new challenges related to symptom management, but also how to manage patients long term, because nowadays a lot of patients live, which is fantastic for all of us. It's live longer, even though at times the cure is not always possible. Next slide, please. So this is a slide that I recently saw in one of the papers that Dr. Eduardo Bruera from MD Anderson published, that talks about these different trajectories of cancer, reflecting the changes that we've been through. So the blue line here, you can see it's sort of the traditional way of how we thought about, and I'll, with the caveat here that I'm talking about primarily solid tumors. The typical trajectory of those patients were that for a long period of time they were sort of declining, but really minimally, and able to preserve their function until the proverbial falling off the cliff happens, when then we saw a sort of rapid decline in patients' function that led to death. And that was the traditional trajectory, and it's still true for some cancers. For example, the pancreatic cancer, where we haven't made that much of a progress, and many of those patients, if they cannot be surgically treated or cured, follow this sort of trajectory of preserving function with some decline, and then sort of fairly precipitous worsening of their function, that leading to death in a relatively short period of time. But now we also have a lot of other trajectories that are actually happening, and we definitely see that in the clinic. One, that sort of lavender line that you see is what we would typically see with patients with who are on targeted therapies for specific mutations, for example, the EGFR mutation in the lung cancer, where many of those patients actually respond dramatically and their function improves to the almost the pre-cancer levels. And many of those patients work, they do really well, they have minimal symptoms. Um, Unfortunately, cancer typically develops a new mutations and the resistance to the drug, and eventually those patients succumb to the disease. But this period of time can be quite long, and it's somewhat unpredictable. And anyone who has been working in lung cancer knows that, the sort of prognosis for patients with lung cancer a decade or so ago was maybe 12 to 16 months, and nowadays it could be years or longer in someone with the mutation that responds to treatment. And then I think the most challenging, in a sense, group is the one with the yellow line illustrates. Those are the patients who are treated with immunotherapy, and they can enter this phase of prolonged survivor, this kind of a wiggly line that makes prognostication incredibly difficult. And Because again, those are the patients with typically metastatic disease who respond to immunotherapy and can live for quite significant amount of time. In small group of patients, and I think that's what makes it even more challenging, is the sort of the purple line here that you see. It's marked by the rapid decline in death, and those are the patients who unfortunately have really a major side effect related to immunotherapy that can lead to actually worse outcomes. And we occasionally see that, fortunately, this is a small group of patients, small percentage of patients, but it happens. But then when you think about anyone starting immunotherapy, you can see how difficult it is to predict how they're going to do, and makes the whole planning and palliative care really challenging. As you can see at the bottom of this slide, the provision of supportive palliative care can really start very early, and we like to start it early. We've talked about this already today a little bit, but then the extent of time that we are involved in patients' lives, it's much longer than it used to be. And I do have patients in my practice that I followed for years and some for decades. And those are patients who oftentimes still have presence of disease. And so that really puts a lot of emphasis on long-term management of those patients. So this is just a couple of highlights. So in the context of this sort of prolonged survivor of patients with metastatic disease, we've really wanted to focus on how do we provide the best care possible for those patients, and got together at 10 academic cancer centers in the US under the guidance of Alliance of Dedicated Cancer Centers, and to start thinking about how can we provide the care that's best aligned with the patient's values and preferences and wishes, and what we call the goal concordant care, and what are the best ways to introduce it in our hospitals. So I think this is something that it's becoming increasingly important, and you would think that every patient, and it's a no-brainer that every patient should get the care that is aligned with their values and preferences, but it's actually not that easy, because if you don't, what we learned is if you don't talk to patients and you do not elicit what's really important for them, the default oftentimes tends to be more treatment, and that's not always the best for every patient, and everyone has different priorities and values. So what we are trying to say is how do we talk with patients and caregivers to make sure that we understand what is the most important for them, and how do we structure the care that actually aligns with those values and preferences in the best way. Next slide, please. So shifting gears a little bit to more symptom management, we also now, again, in the context of extended survival for this patient, struggle with how do we best treat the patient's pain. And you all know we live in the era of opioid epidemic, which certainly has affected the way we treat patients, and it's on everyone's mind. And opioids still remain the cornerstone of cancer pain management for patients with moderate to severe pain, and then can be incredibly effective. there are challenges when it comes to a long-term opioid therapy, because many of the patients who go through the experience of cancer have either pain related to their disease, the primary tumor, or the metastatic disease, or related to the treatments that they received. And oftentimes their pain needs to be managed long-term. So buprenorphine is something that has recently emerged. There's a lot of misconceptions and myths related to buprenorphine that's typically seen or understood as the medicine for substance use disorder. But yet it was developed in the 60s and 70s in England as a safer analgesic, and it's actually an analgesic approved for the treatment of pain. And there are now in the US and Europe for much longer, but in the US we have the transdermal and transmucosal formulations of buprenorphine that, in our view, actually it's underutilized and has a lot of benefits compared to the traditional opioids like morphine and oxycodone, and it's much safer to use long term. And I will not go into the details of the pharmacology of buprenorphine here, but just wanted to highlight how different it is from all the traditional opioids. It really works quite different. It's a partial mu opioid agonist and an antagonist in delta and kappa receptors. And as a result of this really unique pharmacology, it's much safer in terms of respiratory depression. It's has a limited side effects related to the GI tract, so less constipation, less effects on the hormonal function. We know that the traditional opioids, especially when prescribed long term, can affect hormonal levels. Often many men are affected by hypogonadism. There may be some other issues related to it. In fact, buprenorphine can also potentially affect the mood and improve the rates of depression. So there are many benefits of it, and we feel that for many of the patients who do need to be on pain medications, buprenorphine makes a lot of sense, and we actually are in fact pursuing some clinical research in this right now to really prove that this might be a preferred agent for many of the patients. And also another thing that I wanted to highlight, happy to talk more about, is the use of medical cannabis. Many of our patients ask about this. I think there's also a lot of misconceptions about what it can or cannot do. This is just the most recent map I updated, I think a couple months ago, that shows sort of the different levels of approval for cannabis across the country. There's more than 30 plus, I think, states now with some medical cannabis laws. But there's still, of course, the gap between the federal government and their regulations and cannabis. It's still considered Schedule One, and the state law. So we sort of exist in this dichotomy, but also with a lot of interest coming from patients who typically want to use it for symptom management. Next slide, please. And there is a lot of preclinical data that we have about cannabis that it can actually be quite helpful for a lot of symptoms. We do have our own endocannabinoid system, and that's a sort of like a brief graphic describing the receptors, the CB1 and CB2 receptors, and the ligands, the endogenous ligands that we have. The phytochemicals contained in the plant of cannabis, that mainly the THC and CBD, although we know there's close to 100 of different phytochemicals, can affect on our system. And the endocannabinoid system regulates things like mood and appetite and relaxation and many other functions within the body. And we only are starting to understand this. It actually, one would think that this could be a potentially a useful tool for management of many symptoms. There are many challenges, though, related to practical challenges. And I see also a fair amount of elderly patients who are interested in this, and the whole process of getting certified is relatively easy. However, then the appropriate monitoring and guiding patients for this process is not always straightforward. And we have been certifying patients in our practice for the last several years since the law became available in Pennsylvania. And have built some experience with this, unfortunately, I think that a lot of times patients don't realize how sort of how much work it's needed to really figure out the best combination of cannabis products that can help them in managing of their symptoms and how to best and safely fit it into their all other algorithms of treatment. So happy to expand on this, and thank you for your attention.
Okay, thank you so much, Dr. Chiswick. We appreciate your time so much. We are now going to move to the panel portion of today, and it's my pleasure to introduce to you our panel moderator, Marianella Napolitano. Originally from Ecuador, Marianella moved to the United States to pursue her undergraduate degrees in Information Management System and Nursing, and later decided to pursue an MBA in Healthcare Administration. She has over 15 years of progressive leadership experience in the healthcare industry, working mostly to support providers serving vulnerable populations and implementing population health strategies such as PCMH concepts, meaningful use adoption, EMR optimization, and BH integration into the ambulatory setting. She joined United Healthcare in 2020 as the regional director of clinical transformation. In her current role as director of population health, she is responsible for the strategy, implementation, and evaluation of the population health management program for the Ohio Health Plan. Marianella, welcome. Thank you for being here with us today.
Good morning, everyone. Thank you, Lindsay, for that introduction. It's great to be here with all of you this morning. Great to be in company with all of these amazing experts related to palliative care. And I'm very excited and look forward also to the conversation. I learned a lot, I have to say, this morning. So it was phenomenal, all of the information shared this morning. I wanted to start with question specifically around the definition of palliative care. So I started my career as a critical care nurse in the hospital, and many times family used to equate palliative care with end-of-life care. So I'm going to start with you, Dr. Patel. How do you define palliative care, and how can palliative care be reframed to reduce misunderstandings and stigma?
Thank you for that question. So at Nationwide Children's, we actually call our team the Advanced Illness Management Team because of that stigma, and that started years ago. So the way we introduce ourselves is always by calling AIM Team. And then we'll say we're also known as Palliative and Hospice. And then we distinguish the difference between palliative and hospice. Palliative care is for anyone that has a life-threatening or a life-limiting illness. It doesn't matter what your prognosis is. You could be on palliative care for years and years and years. Hospice is truly end-of-life care, and we determine that with families pretty early on when we get involved, just because I think there's a lot of negative connotations when we walk in. And then we also emphasize that a couple of the main goals that we have is, one, to help with decision making and explore what families structure, like what their goals are for their child, in hopes that that can translate into a comprehensive healthcare plan. And then, so besides decision making support, we also help with spiritual support, physical pain support, things like that. So we emphasize the interdisciplinary team notion that palliative care uses, and also the fact that they touch on several domains that are not just limited to end-of-life care.
Thank you for that answer, Dr. Patel. I can imagine that it can be very challenging, right? Like during difficult times, even for people to sort of like understand or comprehend a lot of the concepts and then a lot of the different supports that may be available to them. Dr. Newport, same question for you.
Yeah, you're just starting off with the softballs for us, right?
That's right.
I mean, this is a challenge, right? Because you know, the fact is that we do take care of people who have really difficult conditions, and at times we are helping people to consider their end of life. And so we do have to acknowledge that, right? And so I do think that's important. And so it's kind of a controversy in our field, frankly, of what we call ourselves. And that, you know, we know that any title that you have will soon become equated with the fact that we do take care of people that are in really bad situations. And so we have to acknowledge that that is part of what we do. I think really the bottom line is to demonstrate to people how we can help them to live better. And that's not just our job with patients and caregivers, but also with our colleagues. I think it really, and I see in the chat even that Chad had asked the question about how do we, encourage people to utilize palliative care earlier. And I think it really is based on how we demonstrate our understanding of what matters most to patients and their families, our understanding of the complexities of oncology care, and how we collaborate to be sure that every time we're engaging with patients, we really are meeting them right where they are and focusing on how they live, rather than, just what's coming towards the end. And that really, I think, is a shift. From where palliative care started, we really were born out of kind of the hospice philosophy, to where we are now is helping people to live well with their serious illness. And so it's not something that we can just say, hey, this is the definition on the paper. We actually have to demonstrate it every single day in the way that we care for people and help to align what they need.
Thank you for that. And it's very true. I think that there has been an evolution, right? And I think that there needs to be a continuous sort of like education and awareness. Um, the next question, I want to start with you, Dr. Tristek. It's related to at what point in the cancer diagnosis should palliative care be introduced into the patient's treatment plan?
Right, another easy question. Uh, so yes, that's I think part of the same problem, right? And the continuum. And we started trying to figure it out. We know for sure that none of us want to be involved at the last moment or at very late because we just don't have time to get to know patients. We don't have time to establish rapport. We're coming in as someone who hasn't been involved in one's care, and all of a sudden we're going to talk about goals of care. That's not optimal situation by no means. So I think early, we know early. How early, however, it's an issue because there's been a lot of studies done, and actually we were lucky that I think Dr. Newport mentioned earlier today Dr. Temmel's study, and we participated in the follow-up to that study with a use of telehealth for patients with advanced lung cancer. And I have to tell you that are part of this trial. We saw patients with metastatic lung cancer, and they were referred to our clinic right after the diagnosis. And some of those patients, as I showed the graph earlier, had this EGFR mutation and were started on oral treatment and had absolutely zero symptoms, and felt fantastic. Many of them work, and there was like, okay, so what are we going to talk about? Of course, I think there's still ways to talk to patients, and I really appreciate this opportunity to meet these patients early and start talking about, because on one hand it seems easy because there's no symptoms. On the other hand, everyone knows that prognostication is difficult. So how are we going to actually lead those patients through their experience of illness in a way that helps them live the life to the fullest, but yet we don't forget that they still have incurable illness? And I think this is this inherent difficulty in this kind of situation. So I think, again, back to your question, I think early is better than late. We still don't know how early is appropriate. And another thing I should mention is that we have limited resources, right? There's not a lot of palliative care physicians, and we cannot see every single patient. So how do we really actually, and I think this was mentioned before as well, how much of the primary palliative care are our oncology colleagues are going to do, and who are the patients that would most benefit from palliative care involvement? Still remains the question, I think, to some degree.
Thank you. Dr. Newport, I think you.
Thank you. I just wanted to build on what Dr. Trostek is mentioning is that, now that we are involved with folks who have treatments that help them live longer with a condition that we still think will take their life, has brought in this brand new dynamic of what it's like to live while you still have an incurable condition. And we don't have a ton of evidence of what our interventions are that need to do this. There's no medication that treats this. And particularly for young folks, like we said, who are working, who, are raising children, they have that hanging over them constantly. And so it really is this paradigm that we can help with that they sometimes, don't want to share with their oncology team because it can seem like they're questioning the treatments or, they're not grateful for this great, longevity that they have. But it really is a challenge that folks are dealing with. And so really involving our interdisciplinary team and having palliative care involved, even when they are doing well, is helpful for them to just sit down and talk about those practical decisions. Do I keep working? What kind of finances do I have to worry about? Um, how do I decide how to spend my time? So those are some of the kind of new challenges and paradigms that we're seeing and trying to help people navigate as we have these, great treatments that help people to live longer.
Thank you for that answer, Dr. Newport. And I wanted to build on that. And maybe I can start with you, Dr. Agnew, around probably expanding on some of those barriers to integrating palliative care earlier in cancer treatment and how we can potentially overcome some of those barriers.
Yeah, so that's a really interesting question. So, what we found in our palliative care practice at Ohio State is that there are logistical barriers and there are attitudinal barriers. So, the logistical barriers are, how am I going to manage another appointment in another place with another team or group of providers? And, we mitigated that with an embedded clinic. Now, there's still the attitudinal barriers. Now, an embedded clinic helped with some of the attitudinal barriers. It gave us a lot of time together with the oncology team. They got to know really well what we do and how we help patients. But interestingly, in our clinic in thoracic oncology, over half of patients have incurable cancer, metastatic disease at diagnosis. And yet still only 20% were being referred to palliative care. And it begs the question of, were the other patients, not needing palliative care? Were there no symptoms? Was there, experience not requiring specialty palliative care? Or is there another attitudinal barrier that we haven't even figured out or broached yet? So one thing that we're looking into is self-referral. Does the oncology team need to be a gatekeeper to receiving specialty palliative care? And so that opens up a whole nother set of questions is, you need to explain to a patient what is palliative care so you can self-refer whenever that, appropriate time comes for you. Um, Many patients after they receive palliative care, they say, oh, this is completely different than what I was expecting. And so how do we address some of those challenges and explain palliative care? It really comes down to, how do you explain it? How do you brand it?
Thank you. Same question for you, Dr. Patel.
Yeah, I agree with a lot of what Dr. Agnew said. So one of the biggest challenges, at least in the pediatric world, is in adults, there's not a lot of palliative care providers, and in pediatrics, there's even less. So logistically, there's just not enough people to provide the care that's needed. So that's the biggest one. Even with like hiring more people, training more staff, we're still constantly running into that issue. I think the other big thing is that one thing that it's sometimes it's so provider dependent. If they have any death anxiety or moral distress with calling palliative care or hospice care, I think oftentimes that will prevent providers from actually reaching out to us. So one of the ways we've navigated that is we have trigger consults for a lot of diagnoses. So for example, any child with high grade glioma, for example, will have a trigger consult with palliative care. Any person going through a bone marrow transplant for any reason, we will get a trigger consult. So I think the trigger consults have really helped get us in the door. And then over the past decade, since this hospital has been doing it, it's built a lot of respect between the two different teams in an effort to like help with more consults for like the ones that are not triggers. So I think that has helped. And those are some of the major challenges, like provider distress being probably one that we see quite often, pediatrics.
Thanks, Dr. Patel. Dr. Chistek, you have your hand up.
Yes, I just wanted to mention one thing because I saw a question in the chat about whether palliative care includes other specialties, not just doctors and nurses, and absolutely yes. And I think we do involve social workers, chaplains, volunteers. It's probably team dependent and location dependent, depending what. But yes, it's a very interdisciplinary model. And I speak for myself, but I think we all agree that we couldn't do it without the involvement of other specialties. And I think it also what we bring to for those patients. We talked about patients in the early diagnosis, bringing social workers, bringing others. I think helps to elicit some of this values and preferences of patients, because they do get the supportive therapy and sort of the ongoing longitudinal follow-up, when they can kind of touch base with us over a period of time, and we can help to figure out what are the most important things for them. So absolutely, it's an interdisciplinary approach, and I think every palliative care team does have, depending on the resources, other specialists involved.
Thanks for that answer. I think in my experience, I remember early on when patient-centered medical home became a thing, that the model that we were all looking towards to was palliative care and hospice care. I think that those are teams that really understand that interdisciplinary dynamic. I'm going to go quickly into a couple of follow-up questions related to payment. Dr. Acne, you talk about the logistical embedded clinics. I think one of the questions around payment. How is that payment handled?
Sorry, Marianella, I think that your connection was a little spotty
And
from
the
it. Can you
embedded
repeat the
clinics.
question?
I think one of the questions the question was around the embedded clinician to deliver palliative care, the model that you presented, and how does the physician gets paid?
Yeah, so the reimbursement is no different in an embedded clinic versus a freestanding clinic. It's technically a separate encounter because it's another physician consult seeing a patient in the same location. I think the only difference in reimbursement is many times there's a facility fee associated with an outpatient visit. And so if you're two doctors or two providers seeing a patient in the same facility, there's only one facility fee, whereas in a freestanding clinic, when you're seeing a patient on a separate day, there would be a separate facility fee. So I think ultimately it is less cost.
Thank you. Working for an insurance company, I understand like payment can always be a little bit complicated depending on the type of insurance too. So the follow-up question, I guess, for everybody in the panel, whomever would like to answer this one, it's sort of related to Dr. Patel. You mentioned the trigger consults, and I heard throughout all of the presentations, what a best practice palliative care is. Why are we not doing more trigger consults? Why is that not happening?
I can start, at least in my experience. I think one, it's just a lack of knowledge by providers of what palliative care and hospice care does and the distinction and kind of what we can offer. I think a lot of times they consider the subspecialty a soft specialty versus like cardiology or oncology and things like that. So I think oftentimes, even when they present, a lot of providers, when they present us, they'll make it an option of like, hey, would you like to meet with palliative and hospice? And like most people don't necessarily want to meet. So I think if they reframe it into like, this team can be a sounding board, this team can help navigate longitudinally your symptom burden. This team can help navigate anticipatory grief and bereavement. I think there's so much that we can offer. I think if we were, quote, sold better, I think it would be easier to get into different subspecialties. And I think the other big thing is just we at our institution, we have a pretty decently large pediatric palliative care provider. Like we have 5 physicians, 4 nurse practitioners, 2 social workers, a nurse coordinator. But even then, like compared to the population of the hospital, we're not just seeing patients with cancer. We're seeing patients in the home-based setting. We're seeing patients all around the hospital in different subspecialties. So I think we have had to select which trigger consults we can do versus like some of them that we might just see as needed kind of thing, just from a logistical barrier.
Dr. Agni?
I think it really comes down to supply and demand. There are only so many palliative care physicians, advanced practice providers. And there are many, many patients who would probably benefit from seeing specialty palliative care. And so really making sure that our oncology teams have robust primary palliative care skills so they can address some of those early symptom management questions, coping questions, helps us manage the consult volume. In thoracic oncology alone, we see over 800 new patients every year, and we only have 3 palliative care providers in our embedded clinic. There's no way that we could see all 800 patients, and so a trigger consult would be very difficult and it would overwhelm our palliative care department.
I would add that in addition to the access issue, the trigger consult does not address the issue of whether the oncology team is in support of palliative care involvement, right? And so while the evidence demonstrates that triggers provide earlier palliative care and more effective palliative care, we can all look at that literature, but if the person on the ground who's providing the cancer care doesn't believe in it and doesn't support it, the palliative care consult's actually going to be less effective. Right. So, if a palliative care clinician comes in and is talking about a prognosis that the oncologist doesn't agree with or has not already discussed, then that can actually do harm to the patient and to the relationship with the oncology team. And so there's quite a fine line of initiating triggers and understanding the culture of your cancer institute, of your hospital, to determine whether triggers are going to be effective or not. So if you have buy-in from the cancer team on a specific, tumor type or stage, that's fantastic. And it just means it's one less thing that the oncologist has to think about, and they know that they're going to get the care that they need earlier. But if there's not buy-in, then it can be adversarial, and you may actually have worse relationships. And so it's really important to, assess kind of the readiness of the folks that are involved before you can employ triggers.
Thank you, Dr. Newport. So follow-up question, maybe this is for you, Dr. Tristeg. So how can oncologists and palliative care work more closely together, or, increase the collaboration?
Hmm. Well, a very good question, and I think it's by demonstrating the value. It would be, by showing that we actually can work together, and I think that is very important. So, in my practice, I really always try to touch base with the primary oncology team to discuss things, and to also because oncology is super nuanced these days, and every patient is different, and I need to understand better what they are thinking about, what this patient's possible trajectory might be, and then it allows me to put in a context. We can also sort of through these discussions we can negotiate things that and again, another thing is that of course oncology care is incredibly busy these days, right? There's a lot of things to talk about. There's tests to discuss, imaging to discuss, symptoms, treatment plans. So there's oftentimes not a lot of time left for other things, so we can also discuss and negotiate and sort of what are the things that palliative care team can take on and discuss. We oftentimes take on all the symptom management, making that easier for the oncologist. We are happy to sort of engage patients around the discussions of prognosis if that's what the oncology team wants. But I also always clarify that with them, and I absolutely want to make sure that I understand as well. There's this concept of prognostic awareness that I think is incredibly important, because as uh, our treatments become more and more complex, it is more and more difficult for patients and caregivers to really understand where are they in their trajectory of their illness and what it means. It seems like, they oftentimes hear a lot of things that, emotions take over, and sometimes you walk out of the appointment not knowing really what was said. So I think involvement of palliative care that works closely with oncology allows to sort of really cultivate this prognostic awareness. And it's not a one-time thing, right? It's not, one meeting and we're going to have it all cleared out. No, because it's a dynamic process, so it changes over time. And I think it's really important that, again, goes back to the question of how early is early, because we do need times, and in some instances we need a lot more time to really engage with patients and help them understand what's happening, what are the options, and what those options mean for them. Because it's not just a question of is there another therapy available, but what this another therapy may actually do for you or not do for, and what at what cost as well, right? Kind of understanding these balances is incredibly important. So I think working closely with oncologists, meaning by discussing with them, engaging them early, keeping them informed about what was discussed, what the plan is, and it does help now. We almost all have electronic medical records, right? So it's easier to share the visits, but I think it always better to talk in person if possible or on the phone and then sort of touch base from time to time to sort of cultivate this relationship. And I think it also demonstrates the things that we can do, and then I think makes the referral process easier. So I think my most successful collaborations are those that I know that we sort of understand each other well with our oncology clinic colleagues, and we're working together, and that's all there is, right? It's working together. And now patients and cancer patients actually see multiple teams. They will see GI teams, they will see cardiology teams. So it's not just palliative care and oncology, it's all the other ones as well. So it's sort of, so I think the even bigger question is how do you coordinate all of that care and make sure that patients are not lost in all of this, because that's very easy to do.
That is for sure. It's a complex healthcare system and difficult, for those of us working in it. So let alone for people navigating, difficult disease. Dr. Patel, I know you spoke about like your experience, I think, in both worlds. I'm wondering if you have any additional thoughts related to that. You spoke about the conflicts at times.
Yeah, I think having, at least in this institution, having the ability, like I trained here and then now practice in both areas. And I think that has helped build a lot of the connections. Also, just in general in pediatrics, I think that we talked about trigger consults, and I know they are controversial because it can go either way. I think culture really does matter. Initially, when trigger consults, for example, with BMT were started, we were hitting a lot of death anxiety from BMT providers. And a lot of them were saying, like, our field exists to defy the odds. And how do we defy the odds if someone is coming in and talking about all the negatives, right? So, it was really tough. It took years of us kind of navigating symptom management before they were like, oh, you do symptom management, but you also do other things like help us prognosticate and things like that. So I think in the beginning, everyone is like oncologists, for example, are terrified of symptom management at times when it gets complex. And we have a lot of tools that like we can do a lot of different types of drips on the floor as palliative care providers. So I think them utilizing us in that sense kind of helped gain a lot of respect in other areas because we continued to do other areas of our job. But I think our culture here, thankfully, is very collaborative, but that's not across the board at all. And I think a lot of times it's provider moral distress and their own death anxiety that prevents them from consulting us. So one of the things that I have found effective through medical education forums is actually like having educational seminars with oncologists in what we do, having educational seminars on the importance of basic palliative care skills if a palliative care provider wasn't there. And I know like statistically, they have looked at both adult and pediatric oncologists, the longer they know a patient, the worse their prognostication is. So even like just showing data around that, like the closer you get to a patient, the worse you're going to predict. And having a different set of eyes kind of help navigate the ins and outs of prognostication to ensure that people are meeting their goals of care, both in the hospital and outside of the hospital, I think is important. And I think a lot of oncologists can appreciate that. So lots of education and lots of, honestly, research. Research has really helped because oncology is very data driven. And if you show them the data, then they're more willing to accept it as a need.
Indeed, let data speak. I'm curious though. I think we spoke a little bit about like the controversial trigger consults. I think Dr. Acne, you spoke about supply and demand. Dr. Twistek, you mentioned the collaboration and the coordination of care. So I'm wondering what role, if anything, aside from the oncologists, do other type of providers play in this space, right? If there's not enough palliative care, are there opportunities there? Wondering about your thoughts, Dr. Tristek.
For sure, and again, because I think that speaks to the complexities of symptom management and even medical management of patients with cancer. So we oftentimes engage with our gastrointestinal specialist because there's a lot of invasive scoping that it's needed. We refer patients for interventional pain management to engage them with around the blocks, or even we work with the neurosurgery for intrathecal pump placement. So there's a lot of potential things that are dependent on patient-specific needs to engage others. So I think our team oftentimes serves as a sort of the bridge to help with actually coordinating some of that care as well, and really, and I think what I often see myself is my role as a sort of explaining what each of those teams can do for the patient and why is it important, because patients oftentimes are sick of going to more appointments, right? Like I have to see, my medical oncology team every couple of weeks or often. We come and see you. So it's becomes really burdensome, not to mention the costs and co-pays and travel. We have patients coming from a distance as well, or even from urban areas that may not have resources to come to see us. So it becomes really challenging. But at the same time, I think because of the complexities of the care, it's absolutely necessary. So it becomes more and more of a team sport, so to speak, and I think many teams are engaged, and we can help. I think build some of those bridges as well, and collaborate with our colleagues in other specialties.
I would add that collaboration with the oncology navigators is really valuable. So they often, whether it's a lay navigator or a nurse navigator, they often, understand what's happening with the patient, understand their values, and they often are the folks that will advocate for palliative care to be involved. They also understand the stresses that are on the oncologist, right? Because they're the ones that are, helping them to get through their day and meet the needs of the patient. So the nurse navigators are some of our biggest champions and provide a lot of primary palliative care. They do a lot of triage of symptoms. They're often the ones that will call us and say, hey, we tried this antiemetic, it didn't work. Would you be willing to see the patient? And this, I think, like all collaboration with oncology teams, is so dependent on relationship building. So this is where, like Dr. Agne's model of an embedded clinic is really valuable. I sit next to the nurse navigator in the workroom, right? I know her by name. I know what her kid's doing this weekend, and that kind of relationship just really builds a lot of trust that we're all in this for the right reason. And, we're going to try to do what's best for the patient. So, really involving and making use of navigators. And that can be, it can be a social worker, it can be various disciplines, but that's been really valuable for us as well.
Thank you for that, Dr. Newport. Anyone else related to that? I don't know if Dr. Agnew, you have any additional thoughts there?
Yeah. So there's nothing more powerful than working in the same space as the oncology team. Because the way our clinic is set up is it is a very large workroom where everyone can eavesdrop on everyone else's conversation, for better or worse. And so it's not uncommon that I'll hear a comment across the room about how someone's not doing well, and I'll pipe up, hey, do you need any help? Can I chime in? And oftentimes, the nurses who are completing the ECOG assessment and they're grading the toxicities are the ones to say, oh, we're at a grade 3 toxicity in this particular area. And oftentimes they'll come and stop by my desk and say, you're not involved yet, but I think you need to be. And that spurs a conversation with the oncology team of, hey, can I be of assistance? Does this patient, would they benefit from palliative care? And that alone, I think, is what drives most of our referrals and most of our involvement. And you can't even quantify that in numbers.
And I think to add to that, we like palliative care will go to psychosocial rounds with the oncology psychosocial group. And I think to everyone's point, that collaboration really helps because oftentimes it's a psychosocial team or the nurse coordinator that will notice that there is this need. And oftentimes, like, we don't get necessarily resistance from providers, but they'll just be like, oh, I never thought of it. What a great idea, kind of thing. So I think relationships help a lot.
collaboration is so powerful and yet so hard sometimes. I think there's nothing more powerful, I think, than putting people in the same room together. But even then, sometimes I think, we spoke about culture and, our own biases, perhaps. It takes some time. I don't think we have a whole lot of time left, so I'm gonna transition into the last question, and this is for everyone in the panel, and maybe I can start with you, Dr. Newport, in terms of like how can we ensure that family members are adequately informed and involved in the palliative care decision-making process?
Absolutely. I really appreciate this question. And I think this really does emphasize the role of our interdisciplinary team. I, as a provider, always try, when family or caregivers are present to say, and how are you doing? And they're not always willing or able to share that with the patient because they don't want to burden the patient or they don't want them to feel guilty. So sometimes it's when the patient's walking out and the caregiver says, "Oh, just one more thing," right? So I, as a provider, might not always be able to address those needs. So it's really important. So, we had heard about caregiver support group and how valuable those resources are. And, some of those things that American Cancer Society does to make available, just the validation and recognition of the challenges that families and caregivers have is really important. So using our interdisciplinary team and just acknowledging the difficulty that families and caregivers face is really important.
Thank you, Dr. Tristek.
I absolutely agree, and I think engaging caregivers and then understand they play a significant role for a lot of reasons, right? Like the care of a patient would not be possible if there is no. It's so difficult, and we do see sometimes patients who really actually are somewhat isolated. Like recently I had a telehealth visit with a patient who is in her 50s with advanced GYN malignancy, and her main caregiver was her 91-year-old dad. That is a really significant stressor and situation, and I cannot even imagine. So it's so important that our caregivers are engaged early, and they understand also what's going on, and they also bring their own views sometimes, right? They can be actually different from the patient view. So we oftentimes have to also negotiate this landscape of trying to bring everyone to the same place of understanding, because the caregivers are incredibly important and the patient could not do it alone. Um, and they become our allies and also in managing the patients. They are the eyes on the ground, right? We rely on them, and so oftentimes, we nowadays also the oncological care has become so technologically advanced. We send patients home on the pumps and with multiple medications and who's drains and there's maybe some education before they get discharged, but it's usually not enough. And oftentimes patient, caregivers like, what do I do with this? So and yet, this is the reality of it, that they do need to learn oftentimes how to manage those things. So I think it's sometimes overlooked, but I think incredibly important to involve caregivers very early and really make sure that they understand the whole process as well.
Thanks. Dr. Patel.
I agree with everything that said. I think the physical and psychosocial health of caregivers directly impacts the health of the patient. And I think, so for example, a lot of caregivers will have to quit their job or at least stop working as much. So then that creates financial burden. Who has to, especially in pediatrics, the parents are in charge of providing. So if they can't provide certain things, then how does a household keep running, especially if there's other members in the household? So that's where the interdisciplinary team comes in play. And that's why it's so important to have school liaisons, for example, that help the family navigate the disruption in school and like truancy and things like that. To have social workers that help look for financial resources and help with FMLA. Like the goal is to take as many burdens away from the parents as possible, knowing that it's still a very flawed system, even if you have the best IDT support available. Like it's still very difficult to take all the burdens away. But I think the IDT support is imperative.
Thank you, Dr. Patel. Dr. Agni.
I think one of the most important things I do with every new patient that I see is we really lay out their social network and their sphere of support. I ask who lives with you, who do you rely on, and who relies on you. I want to know every family member that they're in close contact with, and even those family members that they would like to be in closer contact with, the friends, the social support. And by outlining that in my consult note and in my conversations with the oncology team, we can really identify who's going to be really most impacted outside of the patient with navigating the cancer journey.
Thanks, Dr. Acne. I would like to add, actually, on behalf of the payer industry representing the Medicaid plan here in Ohio, from the Health, United Healthcare perspective, I think we traditionally don't tend to be thought of a member of the care team. And I think that Dr. Patel and several others mentioned the burden on the caregiver. There's a lot of support, and we as plans have a lot of resources sometimes available to individuals navigating difficult situations or challenging conditions such as cancer from our care management team, and they can be a part of the team. So I encourage you to expand who you think of when someone within your clinics needs help. So with that, I want to thank each and every one of you. It was an incredible conversation. I learned a lot. I appreciated the time, appreciated your expertise this morning. And I think I'll get to transition it to you, Lindsay, correct?
Yes, that's correct. And to echo Marianella's sentiments, learning so much today. So thank you all for being here. Before we wrap up today, we wanted to share a few resources from the American Cancer Society. Here to share a bit more about those is Pia Banerjee. Dr. Banerjee is a clinical neuropsychologist and the inaugural director of Cancer Innovation and Transformation at ACS. She leads our digital health and care delivery innovation, including several palliative care initiatives. Her career spans executive leadership at health tech companies, cancer survivorship research, and care delivery at St. Jude Children's Research Hospital and UCLA Neuro-Oncology, as well as consulting at the Advisory Board Committee. She completed her undergraduate degree at MIT, her master's and PhD in clinical psychology at Washington University in St. Louis, and her postdoctoral fellowship at UCLA. Thank you so much for being with us today.
Thank you so much, Lindsay. And as Lindsay shared, what an exciting and engaging discussion from the panelists today. So thank you so much for all the things that you shared. And as we think about the challenges that were discussed, I'm excited today to tell you more about what we're doing at the American Cancer Society to try to enhance palliative care and address some of these challenges. So our palliative care programming has 3 goals. The first is to redefine comprehensive cancer care. So all of us here know that palliative care is integral to ensuring that cancer treatment addresses the whole person. So including quality of life, symptom management, and the psychosocial support throughout the cancer continuum. So it's a key goal for us to support access to palliative care for all patients. The second is closing health equity gaps. So ACS is committed to reducing health disparities, which includes finding ways to increase access to palliative care through innovative models and partnerships that especially reach underserved communities. And I'll be sharing some of those with you today. And for the third one, we want to empower patients and providers for person-centered care. So our initiatives are focusing on providers as well as on patients and caregivers to provide greatest impact. Next, please. So today I'll be sharing with you 6 key initiatives at ACS, 3 for providers and 3 for patients and caregivers. And these include a number of collaborations with other organizations, and a couple of these are hot off the press that you get to hear about today. Next, please. So our first initiative for providers is a palliative care webinar series that we recently launched. So our goal here is to enhance palliative care in oncology by better equipping providers. And so these are free and open to the public, and many of these webinars are co-hosted with CAPC, the Center to Advance Palliative Care. So we recently had 2 really exciting webinars, and they had amazing speakers, one on shared decision-making and one on innovative approaches to palliative care. So thinking about how to provide early access and effective scaling. And the way that we structure these webinars is we have the first half of each one focused on state of the science. So what is the latest in evidence-based practice? And the second half is a panel that focuses on implementation. So how do you address all the barriers that may occur, the things that we just heard about today? And so we really wanted to address both the state of the science piece of it, as well as how do we actually do this? And we're going to continue with this webinar series into 2025 with public webinars every other month. And so if you use the QR code that I shared on this slide, it'll take you to a portal where you can see the recordings of these past 2 webinars. And it's also where you can register and see all the future webinars that will be posted there as well. Next. So our next initiative is Enhancing Palliative Care in Oncology Grant Program. And this is with CAPC and was just recently launched. So our goal here is to support oncology teams by enhancing palliative care skills and supporting the development or the expansion of their palliative care programs. So through this program, we are sponsoring about 25 organizations with a CAPC membership. And a CAPC membership gives the entire organization access to their clinical learning pathways, to a number of CE opportunities, and over 50 toolkits on palliative care. And then in addition to CAPC's resources that come with our membership, we're also doing some curated events for these grantees for these 25 organizations. These include case studies, a mock tumor board, and just having open office hours to support on the actual implementation of palliative care initiatives. Next. And our last initiative for providers is our Cancer and Health Equity Support Sponsorship Program. This is with PCQC, the Palliative Care Quality Collaborative. And as we focus on improving the quality of palliative care, we sponsored 15 organizations with a premium membership to PCQC, which is the first nationally unified palliative care data registry. And so as the panelist mentioned today, just a few minutes ago, the concept of letting data speak, and that's something that PCQC really helps with. So they facilitate the collection of standardized outcome measures, often via EHR integration, both for process data from the health system as well as the clinical data. And then they provide benchmarking reports to the organizations to help with quality improvement. So you can see on the right a snapshot of some of the metrics that they provide. And I'll also mention that PCQC's annual virtual palliative care conference called their Quality Matters Conference is actually this afternoon and tomorrow. So if you want to hear more on palliative care, you may be interested in attending that as well. Next, please. So switching now to our patient initiatives. One of our main areas of focus has been on advanced care planning. So as we know, advanced care planning can be extremely challenging for patients. There's emotional barriers, there's varying levels of health literacy, there's difficulty aligning medical decisions with personal values, cultural values, values in their community. And so we have a partnership with Giving Docs to offer a free guided process in completing these important documents, from wills to advanced healthcare directives. And if you use the QR code on the right, it'll direct you to a page that you can share with your patients. It'll direct you straight to being able to, for all 50 states, be able to complete all of those important documents in a guided process. And then in 2025, we're launching a collaboration with Prepare for Your Care. This is an evidence-based program to help patients make these difficult medical decisions. So we wanted to really think about that initial process for patients when they're starting to think about how to fill out this paperwork. What are the types of things that they need to think about? What discussions they need to have with their family members? And we're going to be incorporating their content into new videos on cancer.org. And one really great thing about them is the simplicity of their language. Like on the right, you can see that they say they're here to share stories about all kinds of people and all kinds of decisions. Next, please. We do also have a number of patient resources on cancer.org, and I've provided the QR codes to these. So on the left is a short PDF brochure. It's on palliative care and improving quality of life. This is really a good introduction on what palliative care is and how it can be helpful to the patient or caregiver. So just a good resource as like an introductory one, maybe on your first meeting with a patient. And then in the middle, we have the link to our main palliative care section of cancer.org. So this gives an overview of palliative care and its importance. And so I put a little bit of a snapshot there for you to see what some of those resources are. And then on the right, I've shared the link to our palliative care video series for patients. So this includes some brief information on topics like pediatric palliative care. And we're actually going to have a lot more coming on pediatric palliative care in 2025. Next. And our last initiative was actually just announced last week. This is an advanced care cancer guide that's developed by the National Partnership for Healthcare and Hospice Innovation in collaboration with ACS. So this is, I think, a really neat guide. It's very in-depth. It discusses many aspects of palliative care, including managing symptoms, managing medications. And what I like about it is that it's very hands-on. So it says, if you're experiencing this concern or question, then here's the action to take. So it's very directive in what the patient can actually do. And the appendix is also a great resource. It's filled with QR codes to useful resources and programs. So those are the 6 initiatives that I wanted to share with you today, and we're continuing to ramp up our palliative care initiatives. Ultimately, we are here to help patients live life to the fullest. Thank you.
Thank you so much, Dr. Banerjee. And just thank you to all of our presenters today about the thoughtfulness and all the care that you are providing to patients. We now have one final poll. After hearing from our presenters, how confident are you with your knowledge of issues in cancer survivorship? And while everyone is putting in their adjusted, hopefully, how they're feeling about their knowledge. We just want to remind you to stay tuned for information about our 2025 virtual forum series. Additionally, the CME certificate will be sent out in 2 weeks. That's after you've completed the post-event survey. The survey will pop up at the close of today's session, and you will also receive a post-event email with the recording of the session, as well as that survey link in case you missed it this morning. So looking at our poll results, everyone, it seems like we adjusted our confidence level, which is fantastic. We started out with, I think, about 33% of you said somewhat confident, and we've now shifted towards the other end of the spectrum, which is fantastic. We're also really pleased to tell you that the program from today and all of our previous programs in this series will be available on YouTube. CMEs are only available for the live event, but please share what you've heard here today with your colleagues and feel free to check out some of the sessions that you might have missed. There's a lot of great information on there, and so we hope you'll check that out. Thank you again for joining us today and for your commitment to ending cancer as we know it for everyone. Thank you.